consultant now in cardiothoracic department of Indraprasth Apollo Hospital, and besides CABG, he is also doing heart lung transplant, LAB, procedure, ECMO, and he was earlier director of CTDS department in Asian Hospital, Faridabad, and before that he was in Vedanta Hospital as consultant. And his interests are, of course, CABG, which is Bima. What is this? Bilateral. Bilateral. So all arterial anastomosis, no venous, because we know the results of total arterial anastomosis is better. And valve replacement, repair, heart transplant, LAB, so lung transplant, ECMO. So besides CABG is doing all things related to heart and lungs. So I will request now Dr. Rajeeve Rajput, an eminent cardiologist, to introduce the subject of heart failure. Then he will start Dr. Mukesh Goel will talk. Thank you, Dr. Rajput.
Good evening. Thank you very much, Physician Forum, for giving us this. I'm coming here, I think, twice within a month. I was not in the initial speakers list, but since the topic is very close to my heart, and me and Dr. Mukesh Goel work as a team for heart failure services at Apollo Hospital, so I thought I'll just give a brief introduction, what we are doing in heart failure, and I will just give a background for medical treatment, and then possibly Mukesh will discuss further details of what advanced heart failure treatment we are doing. Dear friends, heart failure is very common because longevity is increasing, life expectancy is more. We are saving the people from heart attack. We are not letting them die of common problems which they were dying of. So they are living longer. Heart failure is an age-related problem. So it's more common now. Millions of people are suffering from heart failure, and it is not a benign disease. It is associated with high mortality, more than many cancers, frequent hospitalization, poor quality of life, and lot of cost to the individual and to the society. There are lots of established treatment options which all of us are aware, but because of the various logistic issues, these utilization of these guideline directed medical therapy is very poor. If I ask you how many percentage of patients of heart failure will be on RAS inhibition, beta blocker, MRA, and SGLT2, it will be less than 10%. That means there is a huge scope of improving upon the medical treatment. If we do not use guideline-directed medical therapy to the fullest, we do not get the maximum benefit. So it is associated with poor outcome. Heart failure, we all know, less than 40% is heart death. 41 to 49% is mid-range ejection fraction, or some people call it mildly reduced ejection fraction, and heart failure with ejection fraction of more than 50% is heart death. Heart failure with preserved ejection fraction. In India, as also in the world, the HFpEF is increasing more and more because people are living longer. The prognosis in HFpEF is only slightly better than HFpEF, but it is also not a benign disease. Just in short, 5 drugs in 4 tablets. That is the guideline directed medical therapy. We all know it. RAS inhibition started with ACE inhibition, then now ARNI. There is no doubt that ARNI is better than ACE inhibitors, and that is the preferred mode of RAS inhibition. Then beta blockers, either you use metoprolol or carvedilol or bisoprolol in full doses, followed by MRA, either spironolactone or eplerenone, and then SGLT2, either empagliflozin or dapagliflozin. So these are the 4 drugs, 5 drugs and 4 tablets. 5 drugs because sometimes army we call it 2 drugs because it is a combination of ARB and neutralizing inhibition which is sacubitril. So 5 drugs in 4 pillars. The famous 5 to keep you out of hospital and alive. That is the. So all the guidelines, all the societies recommend that every patient, unless contraindicated, should be on this. Even after that, if somebody has a heart rate which is more than 70, despite all these 4 drugs, unless some of them is contraindicated, then these are the candidates for ivabradine. So ivabradine comes after these 4 drugs, if heart rate is more than 70. After that, every patient should be screened for iron deficiency. Ferritin, transferrin saturation and absolute iron levels. And if iron deficiency is confirmed, then these patients should be treated with IV iron. Oral iron does not work. Ferric carboxymaltase is easy to administer, very little side effects, allergic reactions, and you can give in 1 gram in half an hour or 1 hour. So that's the beauty of this molecule. Despite that, if somebody has worsening of heart failure, meaning thereby he comes to your clinic with shortness of breath, congestion, and you have to increase the dose of diuretics, that is the definition, or there is a rise in anti-proBNP, or there is symptomatic deterioration, that is the definition of worsening heart failure. And these patients can be benefited by vericiguat, which is cyclic GMP inhibition, increases cyclic GMP and improves cardiac performance. Despite that, many patients will be symptomatic, and if they have broad QRS, left bundle branch block, more than 150 milliseconds, these are the candidates for resynchronization therapy. All patients with ejection fraction of less than 35%, I'm just emphasizing that everybody who has got ejection fraction of less than 35% and at least 2 months or 6 weeks after AMI, all of them are candidate for ICD. ICD can be given either primary prevention without arrhythmia or secondary prevention in somebody who has already had a VT or a survivor of cardiac arrest. Some patients who have advanced heart failure and severe triple vessel disease, if they have viable and ischemic myocardium, which is more than 25% of the LV mass, these are the candidates for revascularization. Not all candidates. So you must do a non-invasive assessment for ischemia and viability, and if that is there, these are the candidates for CABG. Some patients will have significant disproportionate mitral regurg, and there is enough evidence that severe MR in heart failure is associated with worse prognosis. These patients are high surgical risk. So surgery is one option, but more recently in these patients, percutaneous mitral valve repair by mitra clip, which is called edge-to-edge repair, has come as an alternative to surgery, and is QAP trial, it has been shown to improve survival. But having said that, despite all 4 drugs, digoxin, iron, ICDs, combos, everything taken care of, many patients will still be symptomatic. And these patients will be either requiring recurrent hospitalization, will have poor quality of life, and they have reduced survival. So there onwards, this whole starts of what beyond drugs and normal devices, which is ICD and combo. So that part is going to be discussed by my colleague, Dr. Mukesh Goel. Now, just a brief background, for last 4-5 years, we have started a heart failure clinic. We are happy to look after these advanced heart failure patients, and in last few years we have done few LVADs and few transplants, and we are happy to share that all these patients are doing well. There are problems, they are not easy procedures to do, they are not easy to organize, there is a cost, infrastructure, logistics involved, but this is the way forward for those patients of yours who, despite everything, you know they are not be there next year with you. So for those patients, these are the therapeutic options which Dr. Mukesh Goel will discuss. Thank you very much.
Dr. Poddar sir, I'll introduce him and please.
I think Dr. Mukesh Goel, I have already introduced. You can start with talk. He is a senior cardiovascular surgeon in Indraprastha Apollo Hospital. And earlier, as I said, he was in Asian Hospital, and before that in Medanta Hospital. You can start with.
So, good evening everyone, and thank you for being here. So, as Dr. Rajput has already dwelt upon medical therapy for heart failure. Heart failure is basically mismatch between demand of the body and the capability of the heart to supply air. So that's why there is a now a term which we call heart failure with preserved ejection fraction. Because the heart function is itself normal, but because of some abnormality in the diastolic relaxation, it is not able to receive the sufficient blood and not give it to the body. So that's why we get a heart failure. So I will just skip the portion which we have already covered, and I will get to this slide that despite all the current medical treatment, 50% of the patient with heart failure will be dead in 5 years. So what is the advanced therapy? Advanced therapy here means surgical therapy available for patients of heart failure. There is left ventricular assist devices and heart transplant. So how do we identify that which patient now? See, it is very easy for a physician to prescribe patients all these 4 drugs which are hallmark of heart failure treatment, along with the 5th drug ivabradine, and then monitor these patients. But what I have come across that basically we prescribe these drugs, and in Indian reality the follow-up is very poor. Then either we fail to follow because of our busy schedule and the practice or OPD practice, or the patient they fail to follow. So, and we lose track that when they should be referred for advanced therapy. So how do we identify now they should be sent to for a further management? Obviously, severe heart left ventricular dysfunction, which is like 25% or 30% or less, and NYHA class 3 or 4 symptoms. If a patient is okay on medical therapy, like he can go to the office, go to his business and carry out his normal routine activity, okay, continue this patient on a medical therapy. But if this patient deteriorates even despite maximally tolerated medical therapy, and he cannot attend to his routine activity, so please refer him for advanced therapy. And then we have a basically informal cutoff for advanced therapy, like for heart transplant 65 to 70 years and 70 to 75 years for a left ventricular assist device. These are basically keeping in mind the social circumstances, that after that why subject this patient to such a invasive therapy, and the patient should be generally compliant with the recommended therapy, and he should not be on a active like illicit substance or alcohol abuse. Should be affordable because surgical therapy for heart failure is costly, and there has to be adequate social and family support. Basically, if a person in the family is suffering with heart failure the whole family is suffering with heart failure. It is like if a person is in the family is suffering with cancer, the whole family is basically suffering with cancer. So when should we really do surgical therapy like LVAD or heart transplant? So the patient, despite maximally tolerated medical therapy, is in class 3 or 4 symptoms. And why is a class 3 means that basically if he walks even a few steps, 50 meter, 100 meter, 200 meter, he gets breathless. He cannot even climb one flight of stairs. Inability to walk beyond one block basically 200 meter. So cannot walk 200, 250 meters without getting breathless. Intolerant to ACE inhibitors, ARBs, beta blockers, whatever Dr. Rajput said. See what happens that you prescribe these drugs, the patient blood pressure comes down to 60, 70, even becomes more breathless. So it means he is not tolerating medical therapy and he is symptomatic. Diuretic dose means Lasix furosemide more than 1.5 milligram per kg per day. If a patient is of 70 kg and if you are forced to give more than 100 milligram per day because of his congestive symptoms, he is not able to breathe, he is not able to walk, you prescribe diuretic to decongest him, and if it is more than 100 milligram per day, it means he needs further therapy. And what happens with these patients? They get into congestive heart failure, you admit them in hospital and you give them some dobutamine, Milnidone, Lasix infusion, they get better in 2-3 days, then you send them home in all those 5 pillars of medical therapy. And then after 15 days or 1 month, they again come back to the hospital. So what happens? Once they are in hospital, they are confined to bed. You discharge them on medical therapy. And even when they walk like for few days, what happens that they are basically on bed on the at home only. They are not moving around. And as they feel comfortable, they start to move around, they again get into heart failure. So they cannot move at all. So then they again land in the hospital with decompensated heart failure. So transplant is still the gold standard in these kind of patients. But obviously there is some contraindication like advanced age, more than 70. This is more related with, because more than 70 the patients have many comorbidities and they cannot tolerate immunosuppressive therapy after the transplant. Or the government thinks why waste precious donor organs on a patient who is already 70 and past, and why not give it to younger patients? So they are basically behind in the list. Then a patient has a systemic active infection. So there are whole lots of basically contraindications. Then how do we match recipients with a donor organ? ABO blood group, we have to do blood group matching for a heart transplant, and the body size compatibility should be within plus minus 20%. So what it means, like if a male recipient, he is around 75-80 kg, and if we put a heart of a 60 or a 50 kg female, donor female in that, it will fail, it will not be able to cope up with the demand of the body. Okay. And likewise, if the recipient is a very petite female like 40-50 kg, and if we put a heart from a 75-80 kg male in that, so we will not be able to fit that heart into that female. So the body size compatibility should be within 20%, and then we do antibody screen. So how a recipient has general antibodies which have developed against the population. So it should be 0 or less than 20%. So these are few pictures. This is a heart which has harvested from a donor, and this is just before we are packing it. This is sometime when we get a heart from a different city, then we have to transport it through a charter jet. So this is a heart we last November we transported from Mumbai. Children's Hospital. Recipient cardectomy, you can see that the heart is being taken out and it has been excised from the recipient body. The excised heart line, and you can see clearly because the patient was obviously having dilated cardiomyopathy. So the heart size is quite big compared to the normal size. It's a donor heart being lowered into the recipient cavity. This is how we do basically what it looks like and how do we do anastomosis. On the left you can see that the heart has been excised and there is a leftover in the thoracic cavity. Superior vena cava, inferior vena cava, left atrium on the base, pulmonary artery and aorta. So these 5 anastomoses are done to connect the donor heart to the recipient body. So a few of our cases which we did in last 4 or 5 years when we started our transplant. I only started a transplant program at Apollo Hospital, Delhi. So this is a boy which was 5 months old at the time of transplant. And still date, he is the youngest transplant recipient in Asia. There is no younger children in Asia who has received a transplant. And moreover that, he was an ABO incompatible transplant. The boys group was O and the donor group was, the boy group was O and the donor group was AB. And we received a heart from a 18-month-old girl from Gangaram Hospital only. The left side when this boy became 1 year old. And on the left, when he visited us, this boy is basically sent to us by a foreign government. On the left, when he completed 1 year after transplant, on the right, his mother sent us the latest picture when now the boy is 3 years old. This is basically in 2018 when we did our first transplant. This is 7 days after the transplant, the person is going home. I just want to show you picture and I will come to this girl later on when I will be discussing the ventricular assist devices. This is an 18-month-old girl which we transplanted and I showed you the picture of transporting heart in a jet from Mumbai. So we did that transplant for this girl, but I will tell you the later on how the condition was of this girl. And this is the latest picture his mother has sent from UK. And this is our latest transplant. This boy was waiting for a heart for last 3 years. He had a left ventricular assist device implanted by us 3 years back. He was waiting for this. And only last June we have transplanted him. And this is 10 days after the transplant is going home. So the post-operative management of heart failure is basically transplant patient is standard like all the solid organ transplant like kidney, liver, heart and lung. We give triple immunosuppression, tacrolimus, mycophenolate and prednisolone. Prednisolone we taper off after 6 months. And we do surveillance biopsy, endomyocardial biopsy to see if there is any rejection happening or not. So long-term management for heart failure patients is basically either through endomyocardial biopsy surveillance or nowadays what we call liquid biopsy. So that is basically a blood test to see cell-free donor-derived DNA, and if the test is positive then only we do biopsy, otherwise we can keep doing blood test to basically monitor the rejection. But there are obviously some limitations with heart transplant. Organ availability is issue. And I just want to inform you that there is still a general perception that the organs are available in south of India. The people are going to Hyderabad and Chennai especially for heart or lung transplant. But now we have quite a regular supply of organ in Delhi and NCR. We keep getting alert every week at least for 1 or 2 organs which are available in Delhi and around. And the patients, they don't have to go to Chennai and Hyderabad and wait there for months and years living there, living behind their job, their household here, and living there in a flat or a rented accommodation. And not only they are spending on medical treatment, they are spending on their livelihood also. So in Delhi NCR, we have a regular supply. Our organs here from here, because of lack of recipient, are being taken to Chennai and Hyderabad. Because our patients are getting there. Just imagine, organs are in Delhi NCR, recipients of Delhi NCR are waiting in Chennai, Hyderabad for months or years, and then the organs are being taken from Delhi NCR to Hyderabad and Chennai to implant in those same patients. So we have a sufficient organ donation happening in Delhi NCR. So, as with any transplant, there are some limitation, organ availability. Obviously, the patients have to be on immunosuppression. Advanced is a relative contraindication. High pulmonary vascular resistance, because the heart will fail if the pulmonary vascular resistance is high. There might be other comorbidities which prevent this kind of operation, and active systemic infection. So, what are the options for these patients? Is the left ventricular assist device or ventricular assist device? So this was a study long back in New England Journal of Medicine, which studied the effect of ventricular assist device compared to the optimal medical management. And you can see that in the blue there is a medical management over 24 months, and in the red the ventricular assist device and what is the survival. It is itself evident. Then ventricular assist devices, they have evolved over the years. Earlier they were very bulky and HeartMate. Then in 2008 the HeartMate 2 came, and then on the right the HeartMate 3, which we are currently implanting in the patient. So how it works? So it's a pictorial representation, it's a heart. So this is the device which is attached to the left ventricle, and there is an outflow graft, and it is attached to the aorta. So what this does, this device, it draws blood from the left ventricle and gives it to the aorta. There is a drive line which comes out of the patient, and this is a console and the battery. So how do we use LVAD in a particular patient? There are two patients, either it is done to bridge to transplant. It means that the patient is otherwise fit for transplant, but you know that the donor organ is not predictable. It might be available within a week, but it might take years for a matching organ to become available. So, this Sunday night only, I have a girl who is presently in the hospital with end-stage heart failure, ventilator, inotropic support, and we got a call from Mumbai only that they have a 12-year-old donor. The family took time to decide, and that organ was gone. Now we don't know when the next organ will be available. It might be a few months, or maybe 1 year or 2 years or 3 years. So the patients who are sick needs very early transplant, but they cannot wait for the organ. We put a LVAD in them, and so that they can survive till the organ becomes available. So that is called bridge to transplant or destination therapy. These are the patients who are otherwise not fit for transplant because of many reasons, systemic infection, high PVR or comorbidities. So where we put this LVAD as a destination therapy. Moreover, all over the world, more and more patients are now getting LVAD as a bridge to transplant. Even in our last 5 transplants, 3 have been after post-device implantation. Patient selection is very important for these patients, specifically for left ventricular assist device, that the right heart function should be okay and the patient should not be too frail. See what happens with left ventricular assist device. Because left ventricle is failed, and we have put a device to function as a left ventricle. Work index, CVP, tricuspid regurgitation, pulmonary vascular resistance, transpulmonary gradient, right ventricular size, and they become very important. Because the right ventricle is the main ventricle now, the left ventricle function will be taken over by the LVAD. This is just a staging of the clinical condition of these patients who are in critical heart failure, admitted in hospital, requiring a left ventricular assist device. So I just basically lower the number, the sicker they are. Like profile 1 means they are just dying within 1 if we don't do anything. Like 2 inotropes but going down, 3 inotropes but dependent, 4 if they are getting readmitted like this. This will become important when we basically talk about the long-term results of LVAD. And what we have to understand that there is an optimal window, clinical window for these patients. Like if the patient has heart failure, we have designated it heart failure, but if we do it too early, it may not benefit. And obviously every surgery can have a certain risk. And if we have too late, like right ventricle is already failing, or the patient has affected kidney and liver, then only the results will be poor. So, at the present time, more than 8,000 patients, they are on LVAD all over the world, and they're doing fine. And there are many patients who have been like doing fine after even 5 years or 10 years of the LVAD support. Now the results of HeartMate 3 left ventricular assist device are almost approaching 3 year survival with a heart transplant.
Would you like to conclude, please?
Yeah.
Speaker?
Yeah, sure. Yeah. So this I'll show you. This is the last LVAD we did in Apollo. This was done in December. This gentleman is coming back for now heart transplant, and he was suffering with recurrent heart failure. This is how the X-ray looks. This device, this is connected to the left ventricle, and this is a drive line coming out. Another gentleman, we did LVAD 3 years back, and now last year in May we transplanted him after 3 years of LVAD support. So this is how a patient looks. This is a battery pack the patient is carrying, and this is a drive line which exits from the body. So this is the girl I was talking to you about, that 18-month-old girl which we transplanted and got a heart from Mumbai. So this girl was in severe heart failure, intractable heart failure, dependent on ventilator, and she became septicemic, complicated. Bilirubin rose below above 17, platelets came down below 30,000. So we did, because for these small babies, those implantable LVADs are not available, or BiVADs are not available. So we did a Berlin heart, which is a first in India. This device was, this is not approved as a regular use in India. This device was imported with a special license from Drug Controller of India, and this was implanted. You can see 2 tubes are for the right ventricle, 2 tubes are for the left ventricle. This is how the device looks. This is the right ventricular assist, and this is the left ventricular assist. And after we implanted this baby with this biventricular support, her septicemia resolved, she came off ventilator, the tracheostomy was removed, and she started eating. She ate food after 4 months. So we are taking her for a stroll while she is still connected to the console and the BiVAD. And this is the same girl which we transplanted in after 4 months of bilet therapy, first in India. Then a little bit about temporary ventricular assist device, because what we discussed was a long-term ventricular assist device. There are some patients who need a temporary, like a few days to few weeks of ventricular support. ECMO, everybody knows, can be used for a respiratory or a cardiac failure. But the problem with the ECMO is that it has a oxygenator inbuilt. And because of that, there is a more incidence of platelet dysfunction, bleeding and everything, thrombosis, etc. So temporary VAD can be used in patients who have otherwise normal lung function, only require cardiac support. So this is a boy who was around 3-year-old, came to us in 2019 with a myocarditis. We did a biventricular support this boy. After 10 days of support with this biventricular pump, he improved, we removed it, and he went home. And now what are the changes which will be happening in a ventricular assist device? As I have shown you that there is a drive line coming out of the body in the skin and which is connected to the batteries. We might have a wireless charging of LVAD and fully implantable when there is no battery inside. So challenges of long-term therapy are obviously awareness is low, acceptance is low, and it is a very costly therapy. LVAD itself costs ultimate 3 around 1 crore rupees, and the BiVAD I have shown you, it is more than 3 crore rupees. And what we need to remember, how is the clinical course of these patients with heart failure? With every hospitalization, the life expectancy comes down. You might think that we have treated this patient with some diuretic and Lasix and he has sent him home with the medical therapy. But when they come for the repeat admission, which they will come, the life expectancy keeps on decreasing. So, to conclude, the failure of heart failure is a multifactorial treatment. Yeah, it's a concluding style. So, it involves everything: lifestyle changes, cardiac rehabilitation, medication, implantable devices, and heart transplant or transplant. And along with that, we need to spread awareness about organ donation. Regrettably, it is only happening in big hospitals, all in institute and R&R. But not a single Delhi government hospital or other hospitals are basically doing anything for organ donation, though there can be many more organ donations. Thank you for your attention.
Thank you, Dr. Mukesh. It was an excellent lecture. You did first in heart, that one device you used, that was excellent. So will you take questions after the second talk? And we congratulate you for using that device first time in India. Thank you. I will request Dr. Tulsi to introduce our second learned speaker, Dr. Manish.
So friends, after those two excellent talks by Dr. Rajput and Dr. Mukesh Goel, finally we have Dr. Manish Singhal with us, who is one of the best medical oncologists in Delhi, can I say, probably in the country today. And he has been affiliated with the Apollo Hospital for the past 8 years. And previous to that, he was at Noida. And then before that, he was at Cmes. So he's widely known as one of the best oncologists, with a reputation of providing personalized treatment plans that are tailored to each patient's unique needs. This is what is needed today. And his expertise is in various forms of cancers, including CA breast, lung cancer, and head and neck cancers, melanomas, osteosarcomas as well. And his expertise also extends to stem cell transplantation, hematological malignancies as well. And he got the best examination award globally at the ESMO, which is the European Society of Medical Oncology. No Indian had achieved such a great feat as he did. So, okay, now let me proceed further and say a few words more about him. Oncology comes to him as a passion rather than a profession, and has been motivated by his father, who is a cancer survivor for the past 18 years. He is trained and educated at AIMS and has been monitored by the best in the cancer care. Let's have Dr. Manish Singhal on medical oncology. Thank you, friends.
Thank you, sir, and thank you for your kind words. Slightly more unbelievable. I'm not the best. There are many people who are better than me. I'm sure there are. And my father is definitely a cancer survivor for the last now almost 30 years. He got diagnosed in 1996 with a stage 4 lymphoma. And that was the first year of my MBBS. The doctors at that time said, okay, 5 years. And then he recurred again in 2001, 2002. That time a new drug came in, rituximab. And that time he was exposed to rituximab. That got him 8 years. 2010 he recurred again. By the time I was a medical oncologist, so I treated him. And now it is 2024, he is hale and hearty. Touch wood. He continues to thrive that way.
सर जो आपके बारे में बोला गया था वो सही था ना सर?
I'm not the best. So, but yeah. So I've seen oncology developing, and I've seen when rituximab was launched, there were two options with us. या तो बोल मेरो ट्रांसप्लांट करा लो या rituximab करा लो. Rituximab 2001 में सर 1.5 लाख रुपए की थी एक डोज, and 9 lakh rupees of rituximab we had 6 doses we had to take. So 9 lakh rupees of 2001 was quite a huge amount. So we had to sell off a piece of land to get rituximab. We were not sure. Transplant कराएं कि rituximab लें, rituximab के बारे में ज़्यादा पता नहीं था उस समय. But we thought that let's take rituximab so we could save up on the transplant. Transplant mortality was more than 50% at that time. Today transplant mortality is less than 10% or less than 5%. So it was a difficult choice. It was not an easy choice. Nonetheless, the subject of my today's discussion is how to make cancer therapy cost effective. So I'll show you just 2 examples, not to take a lot of time. I know that dinner is waiting. So these are 2 free ward patients. These are not our routine cash patients or patients who pay us, so they don't pay us anything. So this is the case of thymoma. So a 36-year-old lady who used to run a run a beauty parlor. She was a beauty parlor therapist, something like that. So she developed myasthenia gravis, a small time beauty parlor, not a very big one. And she developed thymoma, and it was Masoka stage 3, underwent thymectomy in 2019. And this was consistent with thymoma, and thereafter she had a recurrence of the disease which was biopsied, and it was consistent with thymoma. So she underwent radiation therapy also. I was not treating her at that time. So she received 3 cycles of paclitaxel carboplatin, which is usually the drug of choice for thymoma or high-grade thymoma. I would say low-grade thymoma can be treated with another protocol, but that is also another protocol which is like adriamycin, cyclophosphamide, and platinum. So platinum class of drugs, taxane class of drugs, adriamycin, these are the drugs to be used. But she did not respond, and she had increasing disease, and there was phenomenal disease in the lung. She was not able to breathe. So that is the time that she came to me, and I started her on pacithane. So I started her on oral capecitabine and temozolomide. This is a protocol which is used for neuroendocrine tumors. So now thymoma is also a type of a neuroendocrine tumor. So I thought that let's try this oral therapy, and oral therapy is cheaper. So we gave her 4 cycles of Captan. It looked like that she was responding, but she did not respond to Captan. So there was increasing disease. As you can appreciate in this PET CT scan, the massive disease in the lung, and there is a lot of disease going through the intercostal space, etc. And if you can appreciate, this is the entire disease. A lot of disease in the lung. अब थाइमोमा है तो definitely myasthenia gravis भी होगा, So she had a myasthenia crisis which was treated by the neurology department, and they gave her IVIG, rituximab and so on and so forth. She recovered. She had to be ventilated also, but she recovered. Now I was again, what to give her? She was not in the best of the health to give her chemotherapy again. So I tried something which this is not given in the book. So I tried a Pepsi regime. Now, Pepsi is not the same Pepsi that you enjoy. Pepsi is prednisolone, etoposide, cyclophosphamide and procarbazine. These are all oral therapies. So I gave her Pepsi. Pepsi is usually used for lymphoma. So thymoma treatment is very similar to lymphoma. So Pepsi is a regime which is given for elderly lymphomas where patients cannot take high dose chemotherapy in one go. So low dose chronic chemotherapy, we call it metronomic chemotherapy. Metronomic chemotherapy concept is you treat cancer as if it is a low grade disease, as you treat diabetes, hypertension, something like that. So I thought that let's try it because है तो ये lymphoma की तरह ही, तो lymphoma की वाली Pepsi को try करके देखें. So we gave her prednisolone 20 mg, cyclophosphamide 50 mg per day, capsule etoposide 50 mg per day, procarbazine 50 mg per day. And of course, this you keep giving till the time the blood counts start going down, then you stop, then you give growth colony stimulating factor so that the blood counts can come up and then start again. So you have to keep monitoring the CBC. And lo and behold, this was the disease to start with, this is the disease now. I mean, almost the entire lesions vanished. Practically vanished. This is the disease, this is what it has been reduced to. This disease has been reduced to this, and this disease has been reduced to this. So I told one of my DMB students to prepare a case report. इसको छापो यार, कमाल है, ऐसा तो कभी हमने सोचा ही नहीं, ऐसा तो किताब में भी नहीं दिया हुआ, पर ये तो हो गया. So this case report is being prepared by one of my DMB students. So then she had a phenomenal response, but then as happens in free ward patients, they don't come for follow-ups, they stop the medicine on their own, again she stopped the medicine, again there is some slight increase in the disease, but slight increase. So we have reinitiated the treatment. But she is in much good health, she walks around, she is doing everything. So this is one case. So ugly, bad and good, not the good, bad, ugly, it's the reverse of the ugly, bad and good. So this patient came to me during the COVID peak, and the guy is still living. So he had a large fungating mass in the cheek, and you can appreciate from the length of this this putty that how big it was. ये वो ज़माना था जब 4,500 रुपए का कोविड एंटीजन टेस्ट था. पैसे तो थे नहीं, तो मतलब इसको एडमिट तो कर ही नहीं सकते, सवाल ही नहीं पैदा होता कि 4,500 रुपए तो पैसे ही नहीं है, आने जाने के पैसे नहीं है, तो 4,500 रुपए का कोविड आरटीपीसीआर कहाँ से कराए. So I thought that what to do, and so I started him on a oral metronomic chemotherapy again. So now this oral cancers, especially the oral cavity cancers, especially buccal mucosa, they get phenomenal response with the oral metronomic chemotherapy. Jeftinet, that is Jeftinet, which is used for lung cancer also, 250 mg once a day. Methotrexate 15 mg once a week, and celecoxib, which is a prostaglandin inhibitor, 200 mg week. So I started treatment with this protocol. And I'm not the person to develop this protocol, so definitely not. This is a Tata Memorial Cancer Hospital Mumbai's protocol. And this has been improvised even further now. But that is a different discussion. So I started this patient on this oral metronomic chemotherapy. Jeftinib is available for 1,500 rupees a month. Celecoxib we know is cheap only, and methotrexate is dirt cheap. So you can appreciate that the lesion reduced to this. This is a lesion that there was remarkable reduction within few weeks. Within 6 weeks the lesion was vanished away. Of course, that's not the end of the story. So we are not going to cure patients by metronomic chemotherapy. We know that we can reduce it, so you have to top it up with either surgery or radiation therapy. So we kept giving this till the time the COVID decreased, and we could sort some fund from PM fund. So we get 2.5 lakh rupees from the PM fund. So we completed his radiation therapy, and we completed some oral, some more chemotherapy. The IV form cisplatin is very cheap again. And the disease decreased, Finally underwent a surgery also in that 2.5 lakh rupees of EM fund that we got. And the person is from 2020 to 2024 with such massive disease, he's still living absolutely disease free. Last case, and only one more slide. So poverty, no reason not to treat. Again, metronomic chemotherapy magic. So this patient came to me with this large lip cancer, and so I gave him 4 weeks of metronomic chemotherapy, and the lesion reduced to this. Finally, again, as it happens, they don't turn up for follow-up. I told him that this surgery kara lo, bach jaoge, ho jayega theek. But nothing done, so I don't have any follow-up on this patient. But that's it. So the cancer therapy can be made cost-effective, quite cost-effective. At least not all the time, but at least some of the times. Thank you.
Dr. Manish, please come.
I'm sorry.
We missed you at the felicitation. So before we start the question answer session, I would like Dr. Sethi sir to welcome Dr. Manish Singhal with a plant, with a cup of Physicians Forum of India and Directory of Physicians Forum of India. So Sethi sir in front of the camera.
आप स्माइल आई जाएगी
सर Thank you, Dr. Manish, and thank you, Dr. Sethi sir. Thanks, sir. You can take your seats, sir, now. Please. Thank you. Friends, we are so blessed to have 3 speakers from Apollo. Dr. Rajeeve Rajput, our first speaker, very eminent, senior, very skillful cardiologist for intervention for all electrophysiological procedures. Dr. Mukesh Goel, our friend from Asian, introduced to me initially by Dr. Abha, came on to Apollo and doing wonderful work at Apollo as he showcased it. And Dr. Manish Singhal, about whom I must admit I didn't know much, but he looks to be a thoroughbred oncologist, very grounded and very thorough with his work. We will know as we go along, and we look forward to more CMEs with him. Heard a lot about him from a lot of people. And Dr. Manish is not here today, Manish Gupta. He treated his relative, Dr. Manish Gupta's relative at Apollo Hospital. He is very fond of you. He wanted to be here, he did not come today. We'll start the question answer session.
Sir, but we should have a solo CME with Manish.
Yes, we will have.
He's an excellent donator.
I will give it to our first moderator for today evening, Dr. S K Poddar sir, to give his perspective. Dr. Poddar, where are you, sir? Dr. Poddar, as it seems, has conveniently slipped away to the toilet. He will be coming very soon. Therefore, I will give it to the second moderator for today evening, Dr. J P S Tulsi sir, to take the journey forward and to get the question answer session going on for Dr. Manish Singhal, eminent oncologist, as he showcased with some very simple cases and very simple approaches to oncology. Dr. Tulsi sir.
He's here.
So he is come. Can we have Dr. Poddar?
No.
Okay, let me continue.
Go ahead, sir.
Okay. So those Dr. Manish, was a wonderful talk, and you eliminated at least 2 cases on medical oncology, and amazing results as you showed.
Mike.
Let me take you to 3 very prominent cases. One was on Sanjay Dutt, who had lung cancer, stage 4, and neglected himself. He had backache, and he took painkillers for a while, And then he consulted oncologists like you, and then he was diagnosed to have stage 4 lung cancer. He recovered so well, he's acting, and even while he was going through the chemo, he used to do treadmill almost every day. So those are remarkable, these things. The second case would be regarding Ingrid Adams, very reputed woman, who till today, after having lung cancer stage 4 with distant metastasis including to the brain, is alive today, 10 years after the diagnosis of stage 4 lung cancer. So, like to know about that. And, she was put on leprosy 6 years back. We know this was just by the FDA approved November 2023. But she had enrolled her for this clinical trial 6 years back. And she's doing so wonderfully well. 10 years after stage 4 lung cancer, including metastasis to the brain. How good is that? And the third case would be regarding Yuvraj Singh. He had a primary seminoma. Dr. Poddar would know what is a primary seminoma. Friends? It's a germ cell cancer which originates in the lung. Normally you have seminomas in the testes. So this was again a unique case and he recovered so well. Would you like to dwell on these?
So, the two cases were basically about lung cancer. So, I'll answer both the cases in one go. So, lung cancer is definitely a changing paradigm altogether. Not only because immunotherapy has shown as the light of the day. So, if you look at the long-term results of immunotherapy, even Sanjay Dutt has been exposed to immunotherapy and that's the reason he has had a remarkable response. A very counterintuitive thought process is that immunotherapy should work well in patients who are never smokers. It's actually the other way around. Those patients who are smokers tend to respond to immunotherapy even better because there is a lot of new antigen. So, although it's a very long talk that how does immunotherapy work, basically immunotherapy works by identifying the new antigens, these new antigens in the cancer cells, to identify the cancer cell as a foreign cell and not as your own cell, so that your own immune system can actually fight with the cancer cells and can do away with it. Now, the immune system is a common denominator. You never have zero immunity. So you'll always have some immunity cells who will keep fighting. So immunotherapy helps and boosts your own immune system to fight with the cancer and keeps fighting even when you are not on immunotherapy. So we also have a lot of patients who have undergone immunotherapy and are disease-free and now not even taking immunotherapy and are absolutely perhaps cured. You can use the term cured now because 10 years is a long time. And so immunotherapy definitely has changed, but the ballpark figure of long-term survivors on immunotherapy is around 15%. It's not 100% or 50%. So of course 15% to 20% patients will be long-term survivors. The sooner you introduce immunotherapy, the better it is. There was a time that immunotherapy was very, very costly. It used to cost 4 lakh rupees per infusion for 2 years, every 21 days. And now the cost of immunotherapy has come down to just 10 lakh rupees per year. So you have to just spend 20 lakh rupees for 2 years of immunotherapy because rest of the immunotherapy drugs come totally free of cost. So that is one thing. The other case was Yuvraj Singh is a primary mediastinal seminoma. This is a germ cell tumor. And we know that germ cell tumors are highly curable.
Excellent results.
Seminomas are 98% curable cancers. Even mediastinal seminomas are cured to the extent of 95%. In terms of Yuvraj Singh, BEP is the protocol to be given. BEP is bleomycin, etoposide and platinum. Bleomycin can cause lung fibrosis. In Yuvraj Singh, I know it as a fact that he was treated by Lawrence Hynon, which is the godfather of who developed the entire protocols of seminomas and non-seminomatous germ cell tumors. So in the last cycle, he was not given bleomycin and they changed the protocol to BIP. which is vinblastine, ifosfamide and platinum, so that he can play, because otherwise if he develops a lot of lung fibrosis, he will not be able to play. So they omitted the bleomycin in the last cycle and they changed the protocol to VIP, and he was treated by Lawrence Einon. I met him in this very ASCO meeting which was in Chicago last month in June. So Lawrence Einon was sitting just beside me, and he's a very elderly and very respected oncologist of the world who developed entire protocols for germ cell tumors. But yes, germ cell tumors.
On ROS1 fusion positive tumors. So we know this lady, we're talking about Ingrid Adams, who is alive today. 10 years or a decade after she was diagnosed with stage 4 lung cancer, she's still alive and she was on targeted therapy. Is targeted therapy an immunotherapy? No. So we are talking here about targeted therapy in ROS1 fusion. As we know, ROS1 fusion probably would also be responsible for cholangiocarcinomas and also for glioblastomas. See, so I remember one patient, an Australian pathologist who had glioblastoma, and we know that the prognosis is dismal. So he today is still alive, 1 year after diagnosis of glioblastoma, and he was put on this ROS1 fusion positive inhibitor drug. I am talking about again the same drug which Ingrid took. So talk us about glioblastoma, which is such a difficult tumor to treat. So ROS1 fusion is seen here as well as in cholangiocarcinoma, sir.
So what sir is mentioning is targeted therapies, of course. There are a lot of targeted therapies which have come our way in lung cancer. So the most common was EGFR mutation, which is about 35% patients, and that appears in non-smokers, never smokers. So EGFR mutations is the most common, and of course now we have first generation, second generation, third generation drugs. The second most common is ALK mutation, ALK, that is anaplastic lymphoma kinase mutation. And over there we again have first generation drug which is crizotinib, second generation drug which is alectinib, and third generation drug which is lorlatinib. Then comes ROS1, which is around 1%. So only 1% of lung cancer. Lung cancer being such a common cancer, so even 1% is very important. We have about 3 or 4 patients who are ROS1 mutated lung cancers, and they tend to do very well with targeted therapies. So we know that what is this targeted? So target therapy, of course there are other like BRAF mutation, MET mutations, and HER2 mutations, etc. So target therapy is a therapy, or these mutations are such mutations which drive the tumor. That means the tumor is highly dependent on this mutation to grow. And if you can block this mutation, and you have a small molecule tyrosine kinase inhibitor, which blocks the ATP binding site of that particular mutation, you can block the mutation and you can get better organisms. Of these, ALK mutated tumors have the highest survival, and ROS1 is also very similar to ALK. So if you have ALK inhibitor given in the first go, even with brain met, these small molecule tyrosine kinase inhibitors have brain penetration. That means even with brain disease, they will penetrate the blood-brain barrier with such efficacy that they can control the disease for a long, long time. Now we have 5-year survival data of lorlatinib in lung cancer. 75%, even with brain metastasis, 75% patient will live without any problem and without any speck of disease. So this is something which is definitely remarkable, and there are a lot of newer mutations which they are trying to study, and newer drugs which are being made, third generation, fourth generation, so on and so forth. As far as GBM is concerned, GBM is a bad disease. The bottom line is it remains a bad disease. ROS1 mutation in the GBM is a rarity. You never find ROS1 mutations very common. But of course, if there is a rare mutation, you can definitely treat it. GBM, most of the research in the last so many years has gone down the drain. In 2008, the last paper which was presented was of Rogers 2, which was an NEGM publication. The median overall survival of GBM remained 14 months and is still around 14 months. It has really not changed too much. The treatment remains the same. Surgery karao, surgery के बाद आप radiation और oral chemotherapy, temozolomide लो, उसके बाद तो there is nothing that works. Few mutations like BRAF, NTRK, RET mutations have been found to be there in GBM, but these are rare. The only good mutation is IDH mutation, isosaturate dehydrogenase. Uske again there is a drug. You will be amazed to know the cost of the drug. It is like 28 lakh rupees a month. You have to import the drug, and this is the mutation which is there. Now there are two drugs, ivosidenib and another one which is the same, which is IDH inhibitors, but it is absolutely cost prohibitive. Hardly anybody can buy it. 28 lakh rupees a month.
So any word on skull implantable ultrasound device, with the drugs, two drugs, the doxorubicin and the immune checkpoint blockade antibody in GBM?
Immunotherapy has not shown any remarkable efficacy in GBM so far. Yes, there are some small papers of
Experimental trials are on, sir. Let's hope for the best. Thank you, sir.
Thank you, Dr. Manish. I think we are short of time, so we have some questions for Dr. Our cardiothoracic surgeon, Mukesh Goel. So just one question from my side. You said Albert device can be a bridge therapy for those who are waiting for heart transplant, and it can be a destination therapy. Means those who are not fit for heart transplant, it can be used as a final destination therapy. So how long you can use Albert therapy? Suppose patient is otherwise fit, so Albert therapy it can for how many years it will last, and can it be changed in those patients as final destination therapy?
So, Dr. Poddar, as I have shown in the slide that there are patients who are now for more than 5 years on bed, and because it's a very recent therapy, these are not very like old therapies, and there are patients who were implanted 10 years back and they are still doing well. So the problem with the long-term data is that many of these patients, because they were bridge to transplant, and like within 1, 2, 3, 4 years they get transplanted. As in our last 5 heart transplant, 3 were post-device, 1 Berlin heart and 2 LVAD. So, but the patient who received LVAD and they somehow failed to turn up for the transplant because they are happy with their life. So 5 year, 10 year is okay now. It's a achievable result.
So I think 5-10 years life is, I think it's very meaningful for those patients who may have died. But anyway, thank you, Dr. Chauhan. We are short.
Dr. Goel sir, a wonderful presentation and some wonderful cases. I think the cost of LVAD is very, very expensive, sir. What is the cost of LVAD in your center?
Sir, the device itself costs around 80 lakh rupees, and then the 20 lakh rupees obviously are the hospital expenses. Because these patients, we have to see these patients are very, very sick, and they are basically being cared in ICU. And as you know, in Delhi, every 1 day ICU care costs around 1 lakh rupees. So this is not the cost of the device or the LVAD. Basically, this is the cost of the ICU care. And then when we implant them with the assist device, then obviously they are in the long-term ICU care before they can go home. So 1 crore is a reasonable estimate when the device cost itself is 80 lakhs.
Sir, talking about the definitive therapy, how much does the heart transplant cost in your center?
Sir, heart transplant costs around, basically it is cheaper than liver transplant. And you don't, and in a way it is cheaper than even a kidney transplant because you are not paying and counting for the donors, whatever way. So the cost is around 20 to 25 lakh rupees, where the donor is being provided by the government of India.
Right, sir. What is the longest surviving heart transplant patient in your center?
Sir, because we started transplant program only in 2018, so by God's grace, all our transplant patients are surviving till now. But if we talk of India, so the patient who received first transplant in Cmes in 1994 still survived.
Okay. Sir, I would like to know the maintenance cost of immunotherapy in a heart transplant patient?
So the first 1 to 2 years is definitely a little costly because you are doing blood test or a surveillance biopsy, and the doses of the tacrolimus are a little high. But after 1 year, the cost is around 2 to 3,000 rupees per month.
Right, sir. Good, very good, sir. Very good presentation, Dr. Mukesh. It was an eye opener to see you are doing such wonderful procedures, sir. We wish you all the good luck, best luck. Okay, and we are really impressed with the kind of work that you are doing. Dr. Rajput, sir, you talked about guideline mandatory therapy, medical therapy in heart failure, sir. And you mentioned about the 5 pillars of DDMT. And then you talked about advanced heart failure and talked about very severe heart. Sir, I wanted to know exactly how do you approach a case of heart failure, let's say NYHA 4, and is it slap bang, you start all the medications at one time, and where is the introduction of very severe heart mandated in this journey?
Yeah, I think stage 4, I think these are the very sick patients, so you have to be very careful and start with according to their hemodynamic status, whatever they can tolerate. But I think the basic of guideline directed medical therapy is before they go to stage 4. And you start with all 4. It is very debatable which comes first, but it has been discussed and emphasized in all meetings. It doesn't matter much. As long as you decide that you will introduce all these 4 drugs in 4 to 6 weeks. Sequence doesn't matter much. So if your patient has hyperkalemia, MRA rules out in the beginning. If your patient is hypertensive, army will not be the first choice. So that is your clinical judgment. Very what at the moment is reserved or approved for somebody who has on guideline worsening heart failure. And worsening heart failure has been loosely defined as increased diuretic dose, increased BNP, falling ejection fraction, and poor protocol. Now, the most recent trial is going to be Victoria State from Victor trial. Now, Victor trial is combining 4 and then randomizing very sequent versus placebo in stable heart failure. The logical explanation is if it works with worsening heart failure, it should work without worsening heart failure also. So now there is a next year the result will be available of Victor trial for 4 drugs, and then where do we stand with very sequent and stable heart failure without worsening.
So the topic for Dr. Mukesh was beyond drugs and devices. Now I want to ask Dr. Mukesh and you, because any one of you can answer that question. Suppose I have NYHA2 and I have started drugs in this case. Now if I start even RD and NYHA2, will it delay devices? So that is my question.
100%. In fact, after army and after this guideline directed medical therapy, the number of transplants worldwide have gone down.
Okay. So that is the message.
Many patients have been delisted, and we have seen, you have seen that so many patients coming 2 years, 4 years, now 6 years, 8 years on all these 4 or 3 drugs, whatever they can tolerate. So these are the medical drugs.
Wonderful.
And they can do survival and ejection fraction. And somebody you thought will need transplant next year, not fit enough to do.
Wonderful. Sir, you mentioned about the heart failure clinic. Sir, are you part of the heart failure clinic?
Yeah, I'm a part of the heart failure clinic. In fact, I'm in charge of that.
Great.
And the problem is, which Dr. Mukesh highlighted, all the time we say donors are less, donors are less. But it is the reverse. Recipients are less. Donors we often get on motto alert for heart transplant. That there is a B positive donor in Jaipur, etc., etc. Because you see, when you say recipient, it means a recipient whose recent workup is 1 week back, who is alive, healthy, no contraindication to transplant, money ready, patient ready, relatives ready. So that is the patient who can come. Only thing is, what we normally do is, you ring them up, there is a heart available, they reach emergency, everything has been finalized beforehand. And they come, because we got only 4 hours to do. From picking up a heart and putting it in the new chest for 4 hours.
Great, sir. Sir, just the last question from my side. There are many cases. We know that they have heart failure. They also have very severe pulmonary artery hypertension for pulmonary. And these are the patients who would require a combined heart and lung transplant. Do you have facilities for a combined heart and lung transplant in Apollo, one of the best hospitals in North India?
Sir, thank you, Dr. Chauhan, for raising this question, and we definitely are well equipped to do a combined heart and lung transplant. Because we are already doing heart transplant as well as lung transplant also. So we can do a heart lung transplant too.
Great, sir. And friends, I think it's open now to all of you to ask questions. Or you are done?
Yeah.
You are done. Dr. Vipul, you have a great. Dr. Vipul, my friend, is a cardiologist, son of famous cardiologist Dr. J Mohan, sir. He has a question.
Good evening, Dr. Goel. I have a question. What is the longevity of LVAD? And the other one, second part of the question is prognosis and life after a heart transplant.
So, Dr. Vipul, very pertinent question to ask, definitely. So, the survival after heart transplant is, 1 year survival is approaching 90%. 3-year survival is around 85%. 5-year survival is 75%, and 10-year survival is 65 to 70%. While LVAD, because majority of the LVADs are done as a bridge to transplant. So obviously, but the patients who are receiving destination therapy, obviously there are so many comorbidities. But still the patients who received, many patients like who received LVAD as a destination therapy, at 5 year and 10 years, they are very well, like more than 80% of them, they are living.
Dr. Vipul is an eminent cardiologist, MD medicine. He has done his diploma in cardiology from UK, and he has very difficult shoes to fill. I understand. he appreciates it. He appreciates it himself. Friends, after this wonderful CME, I would say that I have learned 2 lessons. One is that any difficult case in oncology, send to Dr. Manish Singhal. Manish Singhal. Yes. And all the appreciation and I would say tarif that I heard about Dr. Mukesh Goel from Dr. Abha Parashar looks to be absolutely true. It was a pleasure to see Dr. Rajeeve Rajput, sir, and here is wonderful talk on heart failure medications and guideline directed medical therapy. We have learned a lot from you, sir. My honest impression about Apollo is that they are doing great job in every field possible, and they have the best possible specialists, super specialists available in the country. Therefore, take their advantage. At the same time, I would like Dr. Manish Singhal to become closer to us. दिल की गिरह खोल दो, चुप ना बैठो, कोई गीत गाओ. महफिल में अब कौन है अजनबी, तुम मेरे पास आओ. Great celebrations. I would like Dr. S K Poddar, sir, one comment, and Dr. Tulsi, sir, to wind up the session.
I think this section by Dr. Mukesh was very, I think, excellent. We heard first time about that Berlin device. So, and he said that it is used first time in India. So that's brilliant. Elevate device we have had in many hospitals. It was used, but that was, I think we never heard of Berlin device. So congratulations. Very nice talk. Thank you, Dr. Mukesh. Thank you, Dr. Rajput, also for enlightening us about heart failure management.
So friends, to conclude, we've had such a nice talk with our medical oncologist friend, Dr. Manish. The landscape of oncology, medical oncology is changing very rapidly, with a molecule being added probably every 6 months. And we look forward to such more molecules in the future, and our talk and our conversation, deliberation with Dr. Manish Singhal once more. Thank you, sir.
Sir, I would request the entire panel to please come here for a photograph. I would request Dr. L. Parashar to come here and Dr. N. K. Gupta to please come here, and Dr. Chandrasekhar.